Okay, well, that was our last speaker, but we have not finished with the question and answer. And this is Jonathan Trobe speaking. I'm going to take over as the moderator here. Nick Volpe, are you still there, Nick?
I am still here.
Okay.
Yes, I am still here.
So we're going to go right to you first. And I have to say that you introduced some things that I think are going to be rather startling to the audience. The first thing is biopsy. Are you backing off from biopsy and saying, I've got better ways that are easier, I'm going to use ultrasound, MRI? Come on, give it to us straight here. Are you really saying we don't need a biopsy?
I don't know that I'm saying that you don't need it. I'm just telling you that this is a very effective alternative, particularly in the scenario where your pretest suspicion is low. So I'm finding that I'm doing less negative biopsies because I feel very comfortable based on my clinical acumen, the clinical scenario. If I can pass one of these other tests, then I feel comfortable not stacking up a bunch of negative biopsies. I am not a person who ascribes to, I need to have a biopsy, otherwise I can't treat them because somebody's going to sue me someday and tell me I got the diagnosis wrong. If I have a strong clinical suspicion and non-invasive diagnostic tests that support, like fluorescein and ultrasound, then I will skip a biopsy in a very positive case. And alternatively, I'll use these techniques to make me feel comfortable about ruling it out in a low suspicion case.
Well, I think that is, I have to say as the moderator here, and maybe Shlomo, you would pitch in, and maybe Misha as well. I think that that is a little bit of a radical departure that most people in the United States, at least, have leaned on biopsy and have said that they don't trust the other methods, but you're telling us that we should begin to trust some of these other things.
You know, and none of this has been studied in a way that would ever dismiss the gold standard of the temporary biopsy. And by all means, it's just not that big a deal to do a temporary biopsy. But at least for the consistency and flow that I'm having, I'm getting more and more comfortable using this, particularly working with rheumatologists who see a different subset of patients, in using it comfortably to exclude low suspicion cases. And in obviously positive cases that I'm going to treat anyway, I don't feel like I have to be held to a standard that is a tissue diagnosis when there is no alternative in the clinical scenario.
All right, Nick, I'm going to follow up on that. I know that the rheumatologists and the ophthalmologists are not always in agreement about these kinds of things. And would you, if you had a patient who had what you thought was, well, I'm going to ask you to tell us, a negative biopsy, is a negative biopsy on one side will it tell you yes, no, I'm going to treat? What do you need to know with a negative biopsy to tell you that I'm either going to override the biopsy result or not?
Again, I think if the clinical scenario is absolutely classic with a white chalky disc and hand motion vision and impaired flow on fluorescein and a SED rate of 100, who cares what the biopsy is?
All right, what if the SED rate is, what if it's 50?
Again, if the clinical scenario is consistent and it has all these other findings that I only know in that disease, I don't know it in a non-arteritic disease, then I'm going to tend to treat. Again, you can have that discussion with the patient, I guess, at that point to inform it, but I don't, this is a clinical diagnosis in almost every other scenario in terms of rheumatologists, right? They'll diagnose temporal arteritis based on 3 criteria from this column and that column and feel comfortable needing that treatment. And I think we have to own up to the uniqueness of the presentation of giant cell. It doesn't mean there aren't very subtle presentations that you have to biopsy to detect it, but in the classic presentation, that's my thinking.
All right, is there a role for the ophthalmologist in treating giant cell arteritis, or is it our job to make the diagnosis and turn the patient over?
I think it's very important that you continue to follow the patient, mostly because you have a connection with their symptoms that they presented, and to be able to look for subtle findings that might suggest that they're not adequately treated. But in the end, we are not people that should be supervising steroids or tocilizumab on our own. So it really requires a combined effort. I don't think the first 2 or 3 weeks matters because you're going to bomb away with steroids and get things settled down. But at that point, subsequent to that, I certainly don't diagnose and never see the patient again because there are other issues and they often have a blind one eye. You want to monitor the other eye. So I maintain a relationship with patients.
So many of the questions came to you, Nick, and since you're still here,
I
You
am gonna have to depart now, so.
okay, well, one last question.
Yep.
Fluorescein angiography.
Yep.
Several people wanted to know. You mentioned about choroidal ischemia. When do you get fluorescein angiography in your workup of a patient who might have giant cell?
So in any patient that has an ischemic optic neuropathy presentation that I think is consistent with giant cell, or I'm unsure, or it's one of those marginal cases where the SED rate's not helping me, I think the fluorescein could be very, very helpful in that scenario. Possibly in patients with transient visual symptoms, the fluorescein can be very helpful in that setting if it's transient choroidal ischemia. So those are two classics. And again, if I'm looking to have positive ultrasound and a chalky white swollen disc with hand motions vision, and I want to just nail it down one more time without a biopsy, I might do it in that scenario.
Okay, well, we'll let you go off to see your patients.
Actually,
Nick,
have a great day.
Really good. You handle those questions.
I'm
I've got some tougher ones for you, but you're going to escape those. All right, Misha. Misha, are you there?
No, Misha is not here.
Misha is not there. Okay, so then it's going to be up to us, Shlomo, to try to handle some of the things that came up both for my talk and for Misha's talk. Dr. Pless's talk, several people wanted to know, are we still using the ONTT guidelines, the optic neuritis treatment trial guidelines in the treatment of optic neuritis? And maybe I'll speak first on this. I was involved in the optic neuritis treatment trial and in the writing of the papers in the New England Journal, so I'm rather familiar with it. I think that here's my overall view of this. In the past, it was always said that the treatment of optic neuritis with steroids was kind of optional. And the reason for that was there's really no very good evidence from the optic neuritis treatment trial that the treatment is really very much good. It maybe hastens recovery, but not very much. And I don't think you could defend the use of corticosteroids in the treatment of typical optic neuritis on the basis of that. It's really not very effective. You'd think it ought to be, but it isn't. So now you have to say that you are going to do it partly because the patient wants it, or because you want it and because it's logical, but honestly, the evidence is not there. So I think that's the first point to make. The problem is that we now have these other things called MOG and neuromyelitis optica, where we do think that steroids make a difference. Certainly that is true in NMO, that's neuromyelitis optica, and you may even need more than that, more than steroids. So it's become a complicated thing. It used to be said that you'd want to treat optic neuritis if you're an ophthalmologist on your own. Now I think it's become so complicated that my advice to you would be that if you are an ophthalmologist, you unload that patient as quickly as you can, either to a neuro-ophthalmologist or a neurologist. Be careful with neurologists because they don't know how to examine the eyes most of the time. I mean, I'm trained in neurology, and I can tell you that most of my colleagues in neurology don't want any part of the eyes. And so you have to be very careful. Shlomo, what would you say?
Well, first of all, we treat all our patients, that's one, with steroids. And the reason would be that nowadays we have also the MOG and the NMO, that's one. And two, we have those patients with neuroimmunology. Neuroimmunology is a new an older subspecialty of neurology, and they take a very good part of the treatment of these patients with us. Okay, so we play ping pong with neuroimmunology, and they do the neuro part and we do the eye part. But we obviously and certainly do treat our patients. And of course, the serology in case of MOG and NMO takes time. And until we get the results, the patients are treated.
So let me turn to back to the giant cell arteritis. Some of you wanted to know about the role of tocilizumab, which is this IL-6 inhibitor. I would have to say that the rheumatologists are more enthusiastic about it than the neuro-ophthalmologists, in the United States at least. And the reason for that is that tocilizumab is not a very often well tolerated, and it's very expensive. Steroids are not expensive. Tocilizumab is extremely expensive, at least in the United States. And so there have been some questions about its role. I would say that I would agree with Dr. Volpe that you use it in combination with steroids, but certainly not as a replacement for steroids. And many people have found that it is just not as nearly as good as we hoped it would be. I mean, at the moment, I think we are still stuck with steroids. Many of you wanted to know how quickly do the patients get tapered off their steroids, and that is very controversial. There really are not many great guidelines on that. But the rule that I use is I try to get the patients down to around 10 or 15 milligrams of prednisone or prednisone equivalent oral dose within about a month and a half of the diagnosis. Otherwise, you are submitting your patients to the side effects of chronic steroids, and they are plentiful. And you do not want that to be happening. Another thing that came up here, there were several things that had to do with optic disc swelling, which was my topic. One of you asked about nutritional optic neuropathy. Why is that not on the list of the swollen disc? And the answer is that very few cases of nutritional optic neuropathy produce much in the way of swelling of the optic disc. It's a retrobulbar phenomenon, which does not seem to produce much optic disc edema. So I don't think it really belongs on the list. And the same thing would be true of toxic optic neuropathy, which in many ways is more common. And that would be especially ethambutol. That does not typically produce much in the way of optic disc swelling. So that's a retrobulbar process. The other thing that I want to go back to is the patient who you think might have giant cell arteritis when there is no optic disc swelling. Dr. Volpe mentioned to you that a very small percentage of patients with giant cell arteritis and optic nerve disease have no swelling. A very small number have no swelling. The vast majority of them will have swelling. So already you're on a very small percentage of patients if you are looking for a diagnosis of giant cell arteritis in a patient without a swollen disc. You can't ignore that possibility, but it's there. Shlomo, what would you say to that?
Yeah, I want to go back to your remarks regarding tapering of steroids. ESR, the erythrocyte sedimentation rate, has a great role in my way of tapering down. So I'm tapering down the steroids well, whether the ESR goes down or not, and the way it goes down. So whenever the ESR is still high, I give it a little bit more time to go down. And you told me that whenever the sedimentation rate doesn't go down, okay, you have to open the diagnosis.
Yeah, this is another one of those difficult things. Many people want to know what do you do with a patient who has a rebound? You get the dose down and the sed rate goes up again. That's a very difficult problem. This is why I asked the question to our audience about whether you take care of patients with giant cell arteritis or whether you just make the diagnosis. My guess is that most of you are not taking care of these patients. You're maybe looking at them, but you're letting somebody else, maybe an internist or a rheumatologist, make the decision about the use of steroid. Yeah, with the possible exception of when the patient complains of a new visual problem, that's when you have to get into the picture again and you have to help the rheumatologist as to whether these new visual symptoms are pertinent to the diagnosis. Very difficult problem, very difficult. There's one other thing that I thought we should touch on, and that is somebody asked about OCT in distinguishing various acquired causes of optic disc elevation. In my opinion, OCT is not at a place where it can make the distinction between papilledema and ischemic optic neuropathy and so on, all those other causes of acquired optic disc elevation. I think that the way you make that distinction is with clinical features, with the history and so on, and not with OCT. OCT is pretty good at distinguishing congenital, that is drusen, optic disc elevation from acquired optic disc elevation, yes, because you can find drusen. But beyond that, I do not think it is very good. Not everybody agrees with me on this, but that's the position that I would take. Shlomo?
On the same topic, we're seeing more and more articles regarding artificial intelligence. Do you think that it will have some role in making this distinguishing or distinction between the acquired and the congenital cases of optic disc swelling? Yes.
I mean, I think one way to end this session this afternoon is what you have heard, or this evening for most of you, is that you've heard some of the classic teachings in neuro-ophthalmology sprinkled with a little bit of the new information that's come in. I would say that that the new information in the diagnosis of giant cell arteritis is still a little bit tenuous. We are looking for more certitude about that as to whether it'll be useful or not. With regard to NMO and MOG, which Dr. Pless talked to you about, that is really becoming clearer and clearer, and is no longer out there as hypothetical. I think that's a very serious new issue. Thanks to the Mayo Clinic in Rochester, Minnesota. They're the ones who helped us with that. And we really do have to take that seriously. Optic neuritis is no longer what we would call your grandmother's optic neuritis. It's much more complex now and requires much more nuanced approach to care and diagnosis. So I think, Shlomo, that's where I would end my commentary and turn it back over to you.
Okay, I think that our time is up. I would like to thank all the presenters for sharing their expertise with us, and to all of you for your continued support for the SOE. It's been a little bit longer webinar than usual, and I am sure that we all earned some of the knowledge that you've taught us. John?
Okay, we're signing off.
We're signing off. Thank you very much, and
have a very good evening, everybody in Europe. And here in the United States, it's still daytime, but we were pleased to combine with you. By the way, several of you wanted to know why there were so many people who were not from Europe. I don't think that's quite true. Dr. Dotan is from Israel, which is really, in a way, part of Europe. Gordon Plant is from the United Kingdom. I grew up in Europe. Misha Pless is from Bolivia and from Switzerland, only lately in the United States. So I do think there was representation from around the world.
This is the way it should be. Thank you very much, and good night.
Good night.